Thank you so much for being here. For those who are seeing this video in post, I'm here with Alessandro and Hammond. He's a graduate student at Harvard University, or yeah, a Harvard graduate and a researcher in oncology and hematology at Boston Children's Hospital. He has collaborated with oncologists at Harvard, Yale, and Memorial Sloan Kettering Cancer Center, accumulating 30 plus publications, including those in leading journals such as Nature, JCO, and BMJ. Thank you so much for being here. I'll go ahead and hand it over to you.
Yeah, so hi, everybody. Today I'll be talking a little bit about some of the advancements in clinical trials. So before I start, I just want to give a brief background on myself. So did my undergrad at Harvard, was a Schwarzman Scholar for a year, and then now doing my MD PhD over at Yale. As Lily mentioned, I was a researcher at Harvard for about 5 years, and my overall goal is really to improve cancer treatments and the quality of life for cancer patients. So I do also have a few hobbies outside of medicine, which include soccer, biking, and then playing a lot of online chess. So I want to point out this really remarkable clinical trial study that was recently in the news over the past weekend. So as you see from the headline, a Huntington patient was treated for the first ever successful clinical trial for it. And so what we saw here was that this gene therapy slowed Huntington disease by about 75%. And so if you look here at this picture in the center, there is a son who inherited the mutant allele for Huntington disease, who was eventually going to get Huntington disease. And for those that don't know, Huntington disease is caused by an expansion of a CAG sequence. And typically what we see in this is after about 40 plus repeats, you'll typically get the disease phenotype. And so often this expansion will result in what we see in an excess in glutamine in the brain, which will often cause this misfolding of the protein. And so that misfolding will actually accumulate in the brain, and it will start filling up neurons until they pretty much start to explode. And so the idea is that this death of the neurons will eventually translate to phenotypes like the inability to walk, or severe dementia. And so, it's no doubt that Huntington disease is quite a progressive disorder. And so what the intervention was here was they had this miRNA. So miRNA uses this complex called RISC, which is it's called an RNA-induced silencing complex. It'll then bind to the complementary sequence of the Huntington protein, and then it'll block its transcription. So the idea is that it'll block it from being encoded into a protein and therefore block the expression of the mutant protein form. And so it was called AMT 130, and they designed a specific miRNA that found a complementary sequence of the HTT, or the Huntington protein mRNA, and then blocked the full expression. And so the idea is that if you don't have it misfolding, you won't have it accumulate in the brain, and you won't have the phenotype of dementia and the inability to walk. And so it was really a remarkable breakthrough that we saw over the past weekend in clinical trials, all possible through the advancement of clinical trials. And so a little bit about my own research and my background. So I spent about 5 years doing blood cancer research. So one of my proudest projects was I helped derive this technique called REDEEM. So it stands for regulatory multiomics of deep mitochondrial mutation profiling. And so it's a method that allows us to trace hematopoietic or cancer stem cells in the patient back to the source cell. And so the idea is that we can actually identify certain mitochondrial mutations and then trace each of these individual cells back to the source cell. So the idea is that we can now do remarkable gene editing work. And so, for example, if we think about something like a liquid state tumor, we can have, through this technology, this multiome capturing technology, which you see here from figure A, which allows you to take, some sort of liquid state cell like a tumor cell or like an AML cell. It'll run it through a multiome capture, and then you'll generate something called a phylogenetic sequence. And so we can actually figure out the source mutation for that, and then figure out or design a drug that targets the mutant protein. And then the idea is that we can now exit or sort of excise the gene that's actually driving a large part of the cancer. And so, this is something that we did in 2022. It finally got published in 2024. But the goal is to eventually, translate this into clinical trials and to do targeted treatments for patients. And so the idea is that, clinical trials for cancer therapies can really improve outcomes for patients. And this is just kind of one example where we're seeing that. And so before we get into my presentation, I just want to sort of talk about a few different things that might actually matter to a physician or to an oncologist. And so typically for an oncologist, there's really four main things that really matter. And they're really thinking about when they're thinking about a new patient. So the first thing is what is the first line of drugs? In other words, what is the overall drugs they can give? And this will heavily depend on the tumor type, the stage of the tumor, and whether the treatment will kill the cancer cells or only stop them in their growth. The thing they'll also think about is the overall survival. The last thing they'll also think about is the progression-free survival, which is how long does it take the tumor to start growing again. And so on the flip side, what actually matters to the patient And so there's really four main things that really may matter to you guys. And so number one is the side effects of the treatment. It's the stress on your family. It's balancing the side effects of the treatment with the progression of the cancer, and it's also the cost of the treatment. And so, one other option is clinical trials. And so, clinical trials are really a way for you to get involved in novel or experimental treatments that are often being targeted towards cancer therapies. And so, one of the best ways that you guys may have known about this already is clinicaltrials.gov. So clinicaltrials.gov, it's a registry that has all of the clinical trials across the US. So if you go there, you type your geographic location, and then you type the specific disease that you want to get treatment for, you'll then find a list of clinical trials. But the problem with clinicaltrials.gov is that it often has a large amount of difficulty to navigate. Many patients will report things like medical jargon or very difficult user interface and a general unfamiliarity with enrolling in the process. And so if you stay tuned towards the end of the presentation, I'll tell you about kind of one tool that I'm working on right now to help streamline and make this process a little bit easier for patients. And so there's really about four main phases of clinical trials. So the first phase, even before it gets to a clinical trial, is the drug discovery phase. And so this will take about 3 to 5 years. And so oftentimes you'll be in the research lab, you'll be kind of splitting your time between the dry lab, the computational work, and then the wet lab, where you're actually doing these experiments in vitro. And if that proves to be successful, it'll then go to a preclinical phase. And so this will then, where you finally start testing on kind of live cells, in vivo experiments, in vitro experiments, and this will be about 1 to 2 years. And so experiments that show high statistical power will then move on to being phase 1 clinical trials. And so phase 1 clinical trials are often concerned with really the drug's safety, efficacy, and dose range. And so they're really thinking about kind of the metabolomics, the pharmacogenetics, how the drug is absorbed, how it's being distributed, how it's metabolized, and then how it's being excreted by the human body. And so the goal is to really figure out kind of what is the maximum tolerated dose that doesn't produce unacceptable side effects. And then if that proves successful, it'll then be going to a phase 2 clinical trial. And so phase 2 studies really determine the effectiveness of the experimental drug on a particular disease, and they'll usually be around 20 to 50 participants. And it'll usually be in this phase for about 2 years or so. And really the main question is kind of what is the quantity of this particular drug that works better on, for example, lymphomas? Does it work better to be taken once a day, twice a day? You kind of sort of get the amount of times the drug should be taken per day. Phase 3 will then be conducted across multiple centers, across usually several hundred participants. It'll then spend kind of maybe the longest lifespan of the drug in this phase. So at about 1 to 4 years. And this is really concerned with the efficacy, the safety, and then all these are certainly randomized and double-blinded studies that are done here. And then if that's successful, it'll then go to phase 4, which will then eventually go to FDA approval after that. And so you might be wondering, why would I actually want to join a clinical trial? And so for one reason, patients can receive new therapies largely before they're available. So remember, that process that I just showed on the previous slide, that's about 10 years before it actually makes it to FDA approval. And so if you're able to join a phase 1 or phase 2 clinical trial, you're able to get the drug halfway through its lifespan. So you're able to get it 5 years earlier before patients are made generally available to this. The other thing is you'll often get a lot more medical attention. So trial participants will usually receive extra medical attention, a lot more checkups, and you'll get really detailed monitoring. And remember, you do have the ability to just stop the trial at any time you want. So, oftentimes these clinicians are monitoring you very, very closely. And so if they don't see a benefit to it, they will just stop the trial completely. There also, for some clinical trials, is a financial incentive. So they could pay you to be part of this trial. And really importantly, you have the opportunity to help advance medical research and help millions of patients after you. And so the idea is that joining a trial allows you to take a real active role in your care rather than feeling limited to standard care options. And so I want to just highlight this really successful clinical trial that we saw. So it was, you see the headline here, woman beats deadly brain cancer with investigational cell therapy, truly amazing. And so here we had a case with a woman, she had glioblastoma, which is a lethal form of brain cancer. And the mortality rate for this is actually about 95%. So 95% of patients will just die completely of this within about 5 years. And so it's really lethal. And so she and other patients enrolled in this clinical trial where they use this thing called a dendritic cell activation. And so dendritic cells are cells that are part of our immune system that use something called the primary antigen presenting cells. And so they'll actually present foreign particles to things like B cells, which are our memory cells, and T cells, which are phagocytic cells that will just completely engulf the foreign particles. And so the idea is that these B cells and T cells will then recognize the antigen and then undergo severe proliferation to fight the infection of the cancer. And so in this clinical trial, they exposed a lot of these dendritic cells of this particular cancer patient. so that the dendritic cells were able to recognize and then attack the tumor more effectively. And so the idea is that they almost pre-trained these tumor cells on the dendritic cells on the tumor cells. And so there was a really interesting trend towards increased survival in glioblastoma with this use of actination. In this case, they used this double-loaded DC or dendritic cell vaccination with this specific drug called DOC1021. And so the idea was that they took the dendritic cells of the patients, they then took the proteins and the mRNAs, and then they allowed these cells of the patient's own dendritic cells to recognize the cancer cells in two different ways. And so the idea was that it increased the chances that the cancer cell would then be attacked and detected by the patient's own immune system. And so the idea was also that they would kind of present these antigen proteins and mRNAs so that the B cells would have produced a lot of memory cells so they would know exactly how to kill the cancer cells and also have enough of those cells to be able to fully engulf all the cancer cells. And so if you look kind of here at the treatment regimen, so they first resected the tumor of the patient. They then extracted the antigens from the dendritic cells to which the patients were exposed. They then activated those dendritic cells by reintroducing them into the patient and then presenting those antigens to the B cells and T cells to then recruit more immune cells. And then you see here about day 9 to 14, they had this thing called neupogen, which is this increased production of neutrophils and dendritic cells, and then this leukapheresis, which is this extraction of the dendritic cells. So they then had this in the dendritic cells, which then they then exposed to these dual antigens with 3 rounds. You can see here that there's first DCV injection, second DCV injection, and then third DCV injection. And so each of these subsequent rounds, they were injecting the patients with the tumor cells. So the dendritic cells were able to fully recognize the dendritic cells. And then mechanistically, if you're curious about how this happened, they leveraged a survival pathway in most cancer cells. So most cancer cells have this survival pathway, which they use. It's called P38 MAPK and mTORC1. And so they allow the antigen to recognize both of these to keep the B cells and T cells active. And so in other words, in this patient, the B cells and T cells were always active. So they were able to fully engulf these foreign cancer cells in the patient. And so what we actually saw, though, was that there was almost complete curing in this woman. So the glioblastoma was fully engulfed by all the B cells and T cells. So it actually fully went away, which is quite remarkable for this clinical trial. Okay, so another clinical trial that I'd love to talk about was this one here, where it says here, cancer vaccine shows promise in preventing recurrence of pancreatic and colorectal cancer. And so for those that don't know, a little background on this, 80% of pancreatic cancers patients will actually experience some form of reoccurrence. And then this will actually happen between 40 to 50% will happen about within their first year of actually getting diagnosed with cancer. And then for colorectal cancer, the reoccurrence rate is likely to be between 30 to 50%. And it'll likely occur within 2 years after surgery. And so you might be wondering, why does this reoccurrence occur so frequently? And so there's really 2 main reasons that we often see. Number one, it's really hard to fully resect the tumor. So these tumors are highly vascularized, they're highly intertwined with the blood. And so to get every single tumor cell out of there is quite challenging. The other thing is that for a lot of these cancer mutations, they're highly genetically intertwined. And so what we'll see is that for some of these, they could be experiencing a loss of one allele for a gene, for a tumor suppressor gene. And since these are often germline mutations, they'll be passed down to offspring. And so you'll have one defective allele. And so oftentimes there's that lack of haplosufficiency to be able to make up for that deficient allele. So you often have an increased rate of mutations that only one functional allele copy. And so what they did here in this clinical trial is, so similar to the one in which they used the mRNA to cancer vaccines, they really used they injected the patient with this mutated KRAS protein. And so this is a protein that drives cell proliferation and activates kinases that drive gene replication. And so the idea is that they drove the activation to the B cells and T cells. So they injected the patient in the lymph node with this mutated KRAS to then have the B cells and T cells be pre-trained on the patient's own cancer cell. And so the idea was that the peptide would act as an antigen to be then recognized by the T cells and B cells to then cause them to proliferate and then give rise to many memory cells that would eventually destroy the mutant protein and also the tumor as well. And so if you look down here on the graph on the left, what you can see here is that the survival curve, it shows here the survival curve. And so patients who were treated had a strong T cell response to the mutated KRAS vaccine. And so they had a much higher survival rate than those that did not. And so the vaccine actually worked quite well and caused for there to be a lot of memory cells, high cell activation, and then for the body to be able to remember how to kill this tumor cells if it were to regrow or to reoccur in the future. So another clinical trial that I want to point out here is this one here where we see CRISPR-based immunotherapy achieves complete remission in terminal colon cancer patient. And so the idea is that when you have a cytotoxic T cell that recognizes an antigen surface on an infected or cancer cell, it'll then release something called perforins or Grand enzymes. And so these are small communicatory molecules that'll then go to foreign particles like cancer cells, and it will cause them to burst or to lyse, right? And so in this case, they had these proteins called immune checkpoints, so that they leveraged, right? So immune checkpoints are these things that are expressed on the surface of these things we call immune privileged cells. And the idea is that they signal for the T cell to then leave the T cell alone, to say, hey, this is a really important cell. We should not disturb it. And so what they did with these checkpoint inhibitors is that, or these checkpoints, is that they had these proteins expressed in all of the cancer cells. And so that the idea was that by binding to these proteins, which are also on the surface of the immune checkpoint system, the cytotoxic T cells will then become dormant instead of attacking the cancer cell. And so one of these immune checkpoints was called CTISH. And so what they did was they actually removed it so that we could stop these immune checkpoints from then being on the cancer cell. And so this is a technique called CRISPR-Cas9, which allows you to design a certain thing or a certain kind of regulatory sequence that'll then go and bind to the gene that's causing some sort of defective issue, and then to completely remove it. And so CRISPR-Cas9 allows you to pretty much cut out bad genes. And so the way that it works is you have this thing called PAM, which is sort of the way that it attempts to base pair with a specific guide mRNA. So let's say you have a really bad gene. In this case, it was CTISH. The PAM designs a really highly specific system where it base pairs to the mRNA, and then once it base pairs, it will then cause a double-stranded break in to disrupt the gene, so then it will remove that defective gene from the cancer patient. So in this case, it was CTISH because it was binding to all those cancer cells, and it was signaling that this is an important cell, and so the immune system was therefore not picking it up, and so it designed the Cas9 to then be able to knock that out, so that it wouldn't have the immune checkpoints, so then you could then detect the cancer cells and then completely overwhelm them. And so, kind of what we saw here is that we targeted the CTISH, we used CRISPR-Cas9, and then we completely knocked it out. And so now it was able to activate all the T cells, attack the tumor, and completely attack and remove the entire tumor, which is really remarkable. And so the specific results here were that all the patients that had treatment severe related adverse events were able to have the tumor completely be gone just by having the CTISH knockout procedure. And so one patient, obviously this is not without kind of issues. And so a lot of the times that you're running these clinical trials, you're often going through, simultaneous chemotherapy and also, immunotherapies, right? This is an addendum to those things. And so one of the patients who had colorectal cancer did not have a full kind of complete response to this. But the others in the study were able to respond, to knock out the CTISH, and then to have almost full overwhelming of all of those cancer cells in the patient. And then so another clinical trial. So here's a video on a particular clinical trial participant where she talks about going through the study, and she talks about how she was completely cured from the cancer. And so this CTISH technique was really able to kind of signal to the immune system, hey, this is a really bad cell, we should attack it, we should kill it. And so it was able to increase the activation or the inflammatory response of the T cells and the B cells. Okay, so another clinical trial that I want to talk to you guys about was this one here, which is called next generation inhibitor for breast cancer. So for this specific breast cancer, and for most breast cancers, they're often having something to do with the estrogen receptor. So for this specific type, it was a ER positive, HER2 negative. So ER positive means estrogen receptor positive. So it was using the estrogen receptor, and then HER2 negative meaning human epidermal growth factor. It didn't have that, right? So the idea was that most of these breast cancers are often driven by issues with estrogen, either not being able to respond to it or lacking the HER2 factor. And so the idea is that when you lack the HER2 factor or the human epidermal growth factor, you're then no longer able to depend on epidermal growth factor for signaling to survive. And so this prevents drugs like Herceptin to then block the receptor to kill all those cancer cells. And so broadly, what we see with the way estrogen works with these breast cancers is that estrogen will actually bind to the receptor, it'll then go inside the cell, so it's a steroid molecule, so it can freely pass through the phospholipid bilayer. It'll then go to the nucleus, drive expression for a lot of these cancer genes, cause a cell to enter, G2S phase, and then cause rapid proliferation. And that's often how we see these breast cancers really go and proliferate. And so typically what we see with trying to kind of remove these in terms of drugs that we currently see on the market, one of them is tamoxifen, which is a chemotherapy drug for breast cancer, and it's a selective estrogen receptor modulator. So it actually will block the estrogen receptor, so that now estrogen can't bind to the phospholipid bilayer, can't really diffuse, and then drive that expression of all those breast cancer genes, or all those genes for that cancer, right? And so the idea is that the cells now can use estrogen less effectively as a survival promoting factor, and so they then can't drive the cancer as much. And so one of the things that was really important as background information for this trial here is that kind of most breast cancers that we see use this mammalian survival pathway, which is called PIK3, AKT, and then M. So the idea is that cancer cells will constantly keep using this pathway to keep themselves alive. So they'll have either transcription factors or regulatory factors that will keep this pathway kind of always active, right? And so one of the biggest things that is coming up in this field now is these things called PIK3 and mTOR inhibitors, which prevent this pathway from sort of constantly being running, so you don't have those constant transcriptional activators going on. And so specifically what we see with breast cancer is also, not only do they have the estrogen receptor going, not only do they also have that survival pathway that I just talked about, but they also overexpress cyclin Ds. So cyclin Ds are these things that cause the cell to enter G2S phase. So that's the phase where the cell starts to do a lot of proliferation. And so they're often overexpressing these cyclin-dependent kinases, right? And so one treatment regimen, which they looked at in this clinical trial, was these aromatase inhibitors. So they block the enzyme that produces estrogens. And so the idea was that they used that in conjunction with the cyclin-dependent kinase inhibitor, which is the thing I mentioned earlier, which caused it to enter G1 or G1S phase. And so that was called osimertinib. And so they used a conjunction therapy in this clinical trial that used both of those, right? So number one was the aromatase inhibitor, and then number two was the cyclin-dependent kinase inhibitors. And so the idea is that also one thing to really be important, or to really keep in mind of here, is that this drug might combine both of those, right? It was called imlunestrant, right? Which is a brain-penetrant ER degrader that constantly removes estrogen receptors, right? So we talked about the pathway, about how that works. But one of the reasons why it's brain penetrant is because a lot of these cancers can actually go metastasize very easily to the brain. So these cancers often will go, that's a high area that uses a lot of metabolic activity. And so they'll go there, and they'll then kind of start a lot of proliferation. That's why these cancers can be very, very deadly or very concerning, because once you start going into glioma space, things can get pretty tricky. And so in this case, what imlunestrant did was that it caused the degradation of this estrogen receptor. So the specific one was ESR1. And so the idea was that these cancer cells were no longer responsible to the pro-survival pathways that were signaling by these estrogens. And so the other one that they also use in conjunction with imlunestrant is one called fulvestrant. So fulvestrant is also an estrogen receptor degrader as well. And so you can see that a lot of these clinical trials are using both estrogen receptors, because that is a really key pathway in driving these cancers. The idea was they wanted to test whether imlunestrant was being effective as an effective estrogen degrader to see if it actually worked on mutated ESR1 mutations. Because the idea is, okay, this drug is great, but let's say, ESR1 is now mutated, right? So let's say there's a mutation now that prevents, the estrogen receptor from binding there now. Can estrogen still enter the cell? Can it still drive transcription? And so what they saw in this clinical trial was that actually a third of the patients had a mutation in ESR1. And so ESR1 is the gene that's often driving a lot of issues with estrogen receptors, and then making the cancer sort of irresponsive or improperly being able to be regulated by estrogen. They saw that 40% of them had already exhibited liver metastasis, potentially probably from the breast cancer, probably being highly vascularized, and then going straight to liver to increase metastasis. And so what they looked at here for the results with this imlunestrant is, so they did number one, a monotherapy, right? So the monotherapy was only imlunestrant by itself. Then they did imlunestrant with the now a conjunction with amselabib, which is that cyclin-dependent kinase inhibitor. And then they just said, okay, well now let's just say how we do with standard endocrine modulating therapy. And what they found here was that among all the patients with the ESR1 mutations or the estrogen receptor mutations, the median survival curve was about 5.5 months. So this clinical trial increased these cancer mutations lifespan by about 2 months. So the imlunestrant group by itself was only about 3.8 months. So 3.8 months right here versus about 5.5 months. And so imlunestrant, had a 2-month increase in lifespan. And so you can see here kind of by the survival curves with imlunestrant, with the conjunction therapy, with a cyclin kinase inhibitor versus the imlunestrant alone, it had, pretty significant increases in progression-free survival as well as overall survival. And so kind of the best treatment for this, in this case, was having that conjunction therapy, using those estrogen receptors, but also the cyclin-dependent kinase inhibitors as well, right? So it was a pretty successful clinical trial, about a 2 point something increase, which is pretty great. So just to kind of recapitulate kind of the findings here, we saw that roughly about 256 patients had these ASR1 mutations. And so imlunestrant alone worked a lot better than the standard therapy alone, but the imlunestrant with the cyclin-dependent kinase inhibitor was the best option among all three of those options, right? And so that was a very good clinical trial. So now to talk about a new clinical trial here, which is this one here where we see inavolisib-based therapy in PIK3A mutated advanced breast cancer therapies. So as a little background for this, when a certain growth factor binds to a receptor, they will often activate this thing called PIK3A, which is a survival pathway that a lot of cancer cells will leverage to then drive their own survival. And so the idea is that activating mutations in this cancer cell survival pathway, PIK3A, causes these cancer cells to proliferate at an extraordinarily fast rate. And so this clinical trial looked at this drug called inavolisib, which is a highly potent selective inhibitor for the alpha isoform of the catalytic subunit that promotes the degradation of P10A. So P10A is kind of the subunit of this survival, this PIK3A. So P10A is a survival subunit, is a catalytic subunit, or the enzyme part of this that's driving the increased proliferation. And so the specific drug they tested here was called polosebimin. And so the purpose of this clinical trial was really to test whether this PIK3 or this cancer cell survival inhibitor was a strong or a potent kind of inhibitor to the cancer's growth pathway, as opposed to just standard estrogen receptor degrader fulvestrant, which is the one I talked about earlier. And so what we found from this clinical trial was really outstanding results. So they saw that the increase in lifespan for progression-free survival was about 15 months in the inavolisib group, versus in the placebo, or the group that had received really no treatment, it was only about 7.3 months. So that's almost double as much increase in lifespan. So this is a really, really fantastic drug that worked really well. And so what we often see here was that in the patients that had this clinical trial, so, obviously there was a few side effects. So one of the ones was loss of neutrophils. So about 58% of the patients had, loss of neutrophils. Neutrophils are the cells in our body that engage in kind of, T cell activation, T cell response, killing of foreign particles. And then we also did see hyperglycemia, stomatitis, and then mucal inflammation in about 5.6 to about 3.7% of the patients. So certainly there were some side effects, but in terms of the lifespan, the drug had a quite remarkable effect. And so to talk about the next clinical trial, so this is one for prostate cancer now. So it's a castration-resistant prostate cancer. So there's a little bit of background. There's something called prostate-specific membrane antigens, which are often expressed on a lot of these prostate cancer cells. So this is the main kind of antigen that's sort of allowing them to survive. The idea is that and just as a clarifying terminology here, by castrate-resistant prostate cancer cells, I mean, even if in this case the genitals are removed, the tumor can still be able to grow, or it can still metastasize. And so what they did here is they tested this small molecule inhibitor, the small molecule called PSMA-617. So the idea is that this PSMA-617 would bind to the PSMA, or the prostate-specific membrane antigen, in the cell, outside the cell, and then it was also linked to this radioactive lutetium-177. And so this is really interesting because it would then expose the DNA of these cells to this ionizing radiation. So it would cause severe damage to all these cancer cells. With the radioactive molecule, it would almost be causing like traumatic experience to the DNA. And so the cancer cells would just kind of die, ideally. And so it was using this antigen binding molecule, which had a radioactive molecule, which was causing that damage to that cancer cell because it was ionizing the DNA. And so the idea was that you would lose a lot of those cancer cells because the DNA of the nucleus is now broken. And so what we found in terms of the results for the study was that this ionizing radiation molecule, 177 LU-PSMA, had significantly increased results in terms of progression-free survival. And so what we saw in terms of the patients that had this drug was 8.7 months in lifespan. So you can see here 8.7 months versus the ones that did not have it was only about 3.4 months in lifespan. So pretty significant survival. And we see here that in terms of the safety, we saw that it was above a grade 3. So we didn't see any adverse events below a grade 3, which is saying that the side effects in this case were not as bad. And so it was a pretty remarkable clinical trial for prostate cancer. And so one thing to be mindful of is that clinical trials are not just about novel treatments. There are also a number of clinical trials. There are also behavioral trials that aren't necessarily testing novel treatments. And so here's a kind of a broad list of all the different clinical trials that we see. So in terms of behavioral clinical trial, these are ways to evaluate or compare ways to promote our kind of behavioral chances. So for example, CBT therapies are often a big one for this. Diagnostic trials, which will then compare the test to diagnose a particular condition. So blood antigen test versus biopsy tumor, which one might be better? Prevention trials. So this will compare methods to prevent the disease. There is quality of life trials. So these are interventions to improve your quality of life. There are also screening trials, which will then compare screening protocols. There are finally also treatment trials. So these are kind of comparing which are going to be the best treatment options for you. And so a lot of the ones that I showed earlier were mainly treatment options. And so just to highlight this clinical trial here, so oftentimes, oncology-related clinical trials are not limited to cancer by testing novel drugs or therapies, but they can also be used to improve your mental well-being. And so in this case, there was a lot of patients that had a poor prognosis of cancer that were at, in this case, an increased rate for depression and a lot of other psychiatric issues. And so in this clinical trial, they developed a targeted approach for CBT to help patients deal with anxiety, depression, and then a few other psychological issues that were associated with the fact that this was a palliative or an incurable malignancy. And so therefore, they were going to have kind of relatively shorter lifespans, and then, an increased kind of visit time or more time sort of in the hospital. And so as a bit of background, traditionally what we see with CBT treatments is that they help people kind of overcome irrational thoughts, beliefs that often will lead to anxiety. And in this case, they had a lot of strategies that kind of helped overcome a lot of the fear, the avoidance behaviors, and also kind of help them kind of put into perspective what really is a rational concern for them going through this cancer treatment. And so what we saw here is that they actually had a sort of a modified course of CBT. So they reduced the number of visits to about 6 to 7 sessions as the patient was going through the cancer treatment. And they allowed the patients to then have these psychotherapy sessions where they would talk with a medical provider kind of over the phone, and then they would sort of talk through kind of what were sort of their, sort of what were their concerns, and then they would sort of help them kind of put into perspective whether this was actually a concern that they had to be concerned about, whether they were actually getting the support they needed, and then also sort of exploring a few other approaches like kind of, breathing approaches, yoga, kind of family support options as well. And the idea was to improve the patient's mental well-being as they were going through this clinical trial. And so what we saw was that of the 20 participants that were assigned to the CBT group, they experienced a significant increase in their mood or their well-being. So that was pretty good in terms of the overall patients. So it did really help them as they were going through the cancer treatment. In terms of the diagnostic trial, and so in this case, what they looked at was they took 2 patients. In this case, this is a lung cancer trial. So it's an early diagnosis for a lung cancer trial. And they really were trying to find a way to increase the diagnosis through these things called autoantibodies in the blood. And so they took patients who were at risk for lung cancer, and then they divided them into 2 groups. And so one group were patients that were kind of given this early CDT lung test. And so they were seeing if they were going to be tested positive for this through doing a blood test, and then also following that up with CT imaging. So they were looking at specific biomarkers in the patient's blood through doing something called ELISA to look at a lot of antibodies. And then they were also sort of following that up with CT imaging. And so what they found was that for about 33 of the 56 patients, they were actually confirmed through their technique to have lung cancer. So stage 3 lung cancer. And then their reliability of this was about 73%. So they had a pretty good accuracy. 52 out of the 71 patients were able to be diagnosed correctly with having the lung cancer based off of these autoantibodies in the patient's bloodstream. And so another clinical trial that's allowing us to now increase our capacity to diagnose and to really assess patients versus having to do a much more invasive procedure like, biopsy the lung tissue. In this case, now we can really take the patient's blood sample, look at specific biomarkers, and then see, whether this patient actually is at a risk or whether they have confirmed diagnosis of blood cancer, or in this case, lung cancer. So the next clinical trial, and this is the final one that I'll sort of highlight, is this one where they really looked at a 3 to 5 year scheduled CAE, which is a carcinoembryonic antigen, and then they looked at that through a T-SCI, or a computed tomography. And so the idea was really to look at kind of whether they could detect recurrent colon cancer. And so what they found was that after about 4.4 years of observation, they detected it successfully in about 199 patients. So they were able to really kind of through this kind of autoantibody screening method, they were able to really detect and see kind of as an early screening method for these colorectal cancer patients whether they were indeed confirmed to have colorectal cancer. And so it was a really kind of non-invasive procedural way to really detect colon cancer. And so there was actually a patient that one of us saw in the clinic where she was actually getting into a clinical trial. And so her name was Maya. She was a 52-year-old patient who had kind of an NF2 gene. She flew all the way from Nepal. And one of her big concerns as she was getting into a clinical trial was this issue of cost. So she had gotten partial funding for this accommodation for this clinical trial, but then she had to foot a majority of the bill for herself, or for a part of the bill for herself and her partner, to come all the way from Nepal to the US. And so that is something that, kind of clinical trials do help you guys alleviate with, because like I said earlier, one of the things that some of them do is they do have, some sort of financial incentive to actually be part of the clinical trial. And so, one of the big things that I think is important to discuss is this financial toxicity in cancer. So this is the term to associate the rising cost with treatments, with insurance policies, especially with patients that, are underinsured. Getting into, standard care options are actually, quite expensive. So kind of this is the average medical cost time for oncology patients, over $1,000, right? And one of the things that unfortunately we don't see as much is that very few oncologists will actually discuss these issues of cost with their patients, right? They'll sort of evaluate the patients, look at diagnostic options, look at treatment trajectories, but then they'll sort of not often discuss these things like cost issues, right? And I think with clinical trials, the really great thing about it is that you'll sort of know from that early on meeting, after you get sort of logged into a clinical trial, whether they're going to fund the whole thing for you, whether they'll give you a really nice financial incentive, which oftentimes they will, which will be really nice, in addition to also getting more medical surveillance through it as well. And so this lack of knowledge about resources is really one of the biggest barriers we see in standard care options. And so I'm going to skip over this slide right now, but I kind of talked about some of the main three things that physicians often think about. And so one of the things that I've now launched is, just launched a company now with my peer over at MIT, where we're now being able to constantly screen patients for clinical trials through their Epic records, and then get them a match for clinical trials. And so we're really trying to revolutionize the way that clinical trials are being done, so that patients early on can be flagged, so that they don't have to spend months or years before you actually get into a really beneficial clinical trial. And so here's how it works. So a physician will see this on their side. They'll then go through, log in with their credentials, and then they'll see kind of all the analytics for all the patients using their system. They'll then see all the relevant patients that are at their hospital. They'll then click on you. And then after they click on you, they'll then have all of your medical information directly logged from your Epic record. They'll then find a list of clinical trials. It'll be almost fully completed. You'll just have to confirm all the details there. And then once you're able to confirm all this, you can then accept the patient into the clinical trial. And then just like that, you've now just found your way into a clinical trial. And so this is a way that we want to now increase enrollment for clinical trials, so that patients don't have to spend months waiting before their physician actually gets them into a clinical trial. And so we also have a patient app for this as well. And so this will be live. This will be live very shortly in a matter of weeks, where a patient you can now go through, see all the list of relevant clinical trials, see your schedule, see different support groups, ask an AI bot any questions you may have about your cancer treatment plan. And then you now can have full autonomy over your clinical trial decisions. And so I just want to highlight one particular patient that we worked with that was able to get into a clinical trial. So her name's Ellen. She was a devoted nurse and grandmother who had been the heart of her small town family for decades. So she's 92. She faced heart disease and then stage 3 colon cancer. And so for her, she tried all the standard care options. Everything failed. And then she had in her tumor a defective mutation. And so she was able to get into this clinical trial called Atomic that was this immune checkpoint inhibitor. And so she was able to see improved survival. She had reduced recurrence, and then she had now a new hope with this stage 3 colon cancer. And so this is just another example of a clinical trial having good success for her. And so for those that are interested, I'd love for you guys to scan the QR code. It'll take you directly to the website. You can sign up for the wait list for when this is out. It'll be out in a few weeks. And we really hope to increase cancer enrollment and to really get patients into clinical trials from the very start. So thank you so much for your time and attention. It's been an honor to present to you guys.
Yeah, thank you so much for being here and for sharing your knowledge about really interesting and promising advancements in the cancer research space, specifically pertaining to clinical trials work. It's greatly appreciated, and hopefully we'll be able to collaborate again soon.